All right, well, I think we can go ahead and get started. It's great to welcome Jerry Azzoli to this afternoon's Cancer Therapeutic Program meeting. Jerry is the leader of Thoracic Oncology at Brown and the Lifespan Cancer Institute, and Associate Professor of Medicine at the Alpert Medical School. And he is going to update us on lung cancer, both clinical care and research. So looking forward to your talk, Jerry.
Thanks, Wafik. I'm new to this format, so please let me know if there's technical difficulties, and I'll try and get through the slides in about 30 to 40 minutes, and would not mind taking questions during the talk if there's a question that comes up based on a specific topic, because this is kind of a survey lecture. Let's see, next slide. There'll be a few slides giving sort of my view of lung cancer care, state of the art, and then, since I'm a medical oncologist, most of the talk will be on the impact of new drugs for the treatment of non-small cell lung cancer. That's where most of the breakthroughs have come in terms of gene-targeted therapies, immune checkpoint inhibitors, and then what is the role of chemotherapy in the modern era. I'll talk about some clinical research protocols that are open and running or pending at Lifespan and Bruag. And some biomarker research as well. And so, in looking at the topics, we've got a FDA approval now of ipilimumab. We're using dual checkpoint blockade and using radiation to try and prime immune responses. So I think now in the era of FDA commercially available ipilimumab, I said it's time to prime. That's the title of the talk. So the requisite slide on why lung cancer is an important topic, because it is by far the leading cancer killer. This is a broad overview of 100 years of lung cancer death. This is that red line is the death rate in men, peaked at 1 death per 100,000 males in 1990. And the death rate has dropped by half over the last 30 years because the smoking prevalence has dropped by half in America. So that's really where we're making an impact in this disease, is by getting rid of tobacco cigarettes in society. And if you look at the female death rates over the century, women learned to smoke later in the last century, but they are learning to quit along with men, and now smoking prevalence in women is down to 12% of women. But still, lung cancer kills more women every year than any other cancer, even more than breast cancer. Our group at Lifespan sees about 500 new lung cancer cases a year. About 10% of them are small cell, and about a third are stage 1 and a third are stage 4. More than half are elderly. And you know, the diagnosis of lung cancer is based on the biopsy. For stage 4 disease, you usually have a small biopsy specimen, but there's enough there for our pathologists to use H&E as well as selected immunohistochemical stains to classify the lung cancer, with the major division being between non-small cell and small cell. But then we know that non-small cell has a number of different histologies packed in, and you know, this talk won't be able to get in detail in any one disease type, except to see this disease as a number of diseases packed into one, each with unique biology and perhaps unique treatments required. And then, in addition to diagnosis, you care about the stage of the disease, and this is the most up-to-date. These are the most up-to-date Kaplan-Meier curves for overall survival based on AJCC stage. These are patients from the 2000s, so from the late 90s through, 2010. And so most of these patients had PET scans. And so I just focus your attention to stage 4 disease. When your cancer has spread through the blood, your non-small cell lung cancer has spread through the blood, median survival time is measured in months, 6 to 12 months, depending on the pattern of spread. So if you have, say, widespread metastases, you won't do as well as if you have a solitary single organ site of metastasis, so-called oligometastatic disease. But regardless of the pattern, your survival time for all comers is measured in months. And so from a medical oncology perspective, that's really where the main progress has been, is that we're turning these poor survival outcomes into fairly decent outcomes. So this is stage 4 non-small cell prognosis based on whether you are just, non-small cell NOS versus having a mitogenic driver and a single oncogene that can be targeted with a single tyrosine kinase inhibitor, such as EGFR or ALK. And if you get the right drug to the right patient, even with stage 4 disease, we're seeing median survival in stage 4 measured in years. And so what we're starting to see is that, stage 4 with a driver oncogene patients are living longer than stage 3 unselected. So the drugs are really changing how we categorize and stage the disease. And I think the 9th edition staging is going to have to take these genetic subgroups into account. And this is just EGFR and ALK, right? So this slide shows all of the clinically relevant subgroups that I think are clinically relevant. Chris Del Preti, one of our senior fellows, wrote up a review article where we made this pie chart with all the different subgroups. A lot of them are defined by oncogenes, EGFR, ALK, ROS1, BRAF, V600E, NTRK, MET, RET, HER2. And then some of them are histologically defined, but without a driver oncogene identified commonly, so large cell neuroendocrine or squamous histology. The most common molecular lesion in lung cancer, non-small cell, is KRAS mutation, accounting for about 1 in 4 patients. And then there are adenocarcinomas without a single mitogenic driver, or histologically unclassifiable subtypes without a mitogenic driver. But you could give a 1-hour lecture on any of these subgroups, but we're looking for all of them in this disease, and we are discovering more drugs to hit the target. So there are now 5 commercially available EGFR inhibitors. Osimertinib is the strongest and is used primarily for ALK. Again, 5 drugs. Alectinib is used as the strongest on-target inhibitor. And there's randomized clinical trial data in all of these, with all these drugs. And so on and so forth for ROS, MET, HER2, BRAF, RET, rarer EGFR mutations, and NTRK. So this is how the field is headed, is dividing it up into genomically defined subgroups. And that raises the stakes on finding these druggable oncogenes as a diagnostic maneuver. And so we're now using more and more blood tests in the clinic where we're just looking circulating cell-free DNA, and if we find one of these mitogenic drivers, we can give a drug in stage 4 disease with a blood test and a prescription that leads to good outcomes. So a lot of people wonder whether we do blood tests on everybody. The answer is no, because the gold standard is still, traditional histopathology followed by molecular pathology from the DNA of the biopsy specimen. But a recent review of what happens when you send DNA routinely showed that blood tests have practical value. So if you send blood and do genomic testing on stage 4 non-small cell, you will find actionable mutations in 6% of cases more often than you will with tissue alone. It corrects false negatives from tissue based on heterogeneity of disease. It it adds comprehensiveness because, you know, for example, in our molecular pathology lab at Rhode Island Hospital, we don't check for all of the druggable oncogenes, we just check for most of them. But the blood test can add comprehensiveness, and of course, blood can compensate for insufficient tissue. So I think that blood tests are here to stay in lung cancer care. And then, you know, the other major topic in a lung cancer overview is the impact of immune checkpoint inhibitor therapy. And I like this graphic because it shows the two main immune checkpoint targets, co-inhibitory targets, namely CTLA-4 and B7. This is an immune checkpoint, co-inhibitory immune checkpoint that functions mostly in the host, in the lymph nodes, the draining lymph nodes near the tumor, where dendritic cells loaded with antigen are talking to T cells. And then those T cells then migrate into the tumor microenvironment, versus the PD-1, PD-L1 interaction that mostly happens in the tumor microenvironment. The point being is that you will see immune cells are being turned on and circulating and moving around the body. And so once again, I think there is a role, there's going to be a role for blood tests or testing outside of the tumor as a way to sample what's going on with the immune system. Here's, once again, just a simplistic view of what happens when you add an immune checkpoint inhibitor to stage 4 non-small cell. You double median survival time to 2 years. This is for patients with a very high PD-L1 score. That's, you know, so I'll go back one slide. So the PD-1 protein interaction, the PD-L1 is expressed by tumors and macrophages in the microenvironment, and you can ask your pathologist to stain for that with a protein test. And if you have a very high PD-L1 score, you can treat the patient with, you know, single checkpoint inhibition with pembrolizumab against PD-1 with 2-year median survival. And then you can just give chemo plus pembro and get the same outcome, nearly the same outcome median, and that's regardless of PD-L1 score. So I'm going to quickly go through those papers, one slide each. So this is the clinical trial of first-line pembrolizumab for stage 4 non-small cell lung cancer, tested negative for EGFR and ALK with a high PD-L1 protein expression. And you can see in a randomized head-to-head, first-line pembrolizumab is better than chemotherapy with a median survival of 2 years and a 40% reduction in the risk of death compared to chemo alone. That was a major breakthrough published now 4 years ago in New England Journal. But what about PD-L1 low tumors? So about a third of patients are PD-L1 high, a third are intermediate, and a third of patients have no PD-L1 protein on their biopsy specimen. So what about those low cases? Well, you can just give chemo plus pembro to all comers, and you see a survival benefit even in the PD-L1 0 subgroup. The publication of this data, about a year or two later, here in 2018, really called into question whether we needed to do PD-L1 scoring. Why bother doing PD-L1 scoring? Just give chemo plus pembro to everybody. So, again, from a medical oncologist perspective of the state of the art, it's sort of like what tools do you have in the toolbox? And I like this overview because it shows the history of ipilimumab, which is the antibody against CTLA-4. So IPI's been around longer. It was first in human 20 years ago, and it was FDA approved as a single agent in melanoma in 2011. And then there's this long sort of cold period with IPI where it sort of failed as a single agent in a number of diseases, and then it was really developed in combination with PD-1, IPI-Nivo combination, ultimately approved in melanoma in 2016. And then in non-small cell lung cancer, we see a host of approvals in the PD-1, PD-L1 antibody arena, but IPI never got approved in lung cancer except in combination with Nivo, and that's only recently. So when it comes to CTLA-4 blockade, single agent ipilimumab and also the synergy with PD-1 has only been demonstrated in melanoma. And so this combination of ipi-nivo, we're really not sure what ipilimumab is bringing to the table in lung cancer care. It's one of those diseases where ipi-nivo is better than chemo, but we don't know if it's better than pembro, okay? And the same may be true for other diseases where you have an approval of ipi-nivo and you're not really sure what the ipi is bringing to the table. But it's FDA approved, so you have to look at the data. And this is the Checkmate 227 study that got it approved. It took a while. And the reason was it was a complicated study with, close to 2,000 patients. They were all negative for EGFR and ALK. And then they were stratified by PD-L1 score. So they were either positive or negative. And so again, about a third of patients with non-small cell will have no PD-L1 expression at all. And so for those who were negative, they were randomized ipi-nivo, chemo, or nivo plus chemo, as opposed to if they had a positive PD-L1 expression, there was ipi-nivo, chemo, and then just plain old nivo in this arm, okay? And then they spent all their alpha on the comparisons in the PD-L1 positive subgroup. So this was the data that got ipi-nivo approved. It was published at the end of last year in the New England Journal. So stage 4 non-small cell lung cancer, some amount of PD-L1 protein on the cancer, negative for EGFR and ALK, and you're randomized to chemo or ipi-nivo. And you see that the curves cross early on, but in the long run, ipi-nivo is better than chemo with a median survival time of 17 months, which you recall isn't as good as the pembro data, but it's good enough to beat chemo and to get FDA approved with a statistically significant result. But what about the PD-L1 0 folks? That's a third of patients. And in that subgroup, the impact of ipi seems even more impressive. Here we see a much larger distance between ipi-nivo and chemo in terms of the benefit, but they couldn't do a statistical comparison of this apparent benefit because they had spent all their alpha on the PD-L1 positive subgroup. But it looks to me like these are the patients where we really need the ipi because they do so poorly with chemo alone. And you'll see that if you have PD-L1, you seem to do better than if you don't on chemo alone. And there's crossover involved and things like that. But so if I were to say when would I want ipi, it would be in a PD-L1 0 subgroup where pembro doesn't work as well. But it's not FDA approved for that indication. At ASCO this year, Suresh Ramalingam presented a 3-year update on this data. And here we see the Kaplan-Meier, the curves in the PD-L1 positive patients. Ipi-nivo is better than chemo. And then here you see that nivo alone was sort of in the middle, intermediate. And it wasn't statistically significantly better than chemo. And nivo-ipi was not much better than nivo alone, but a little better. And there's a very impressive 3-year survival proportion of 33%. But once again, the curves cross. And then what about the PD-L1 lows? Here the curves don't cross because the chemo folks do so poorly. And once again, ipi-nivo seems superior. But this did not win FDA approval. So what do? If the curves cross here, then give chemo to everybody. And so this is a study, it's called the 9LA study, first-line chemo plus ipi plus nivo, 3 drugs versus chemo alone, head-to-head. But both arms got chemo, right? And so the curves don't cross, and then ipi-nivo chemo, I'll call it the kitchen sink, does better than chemo alone. But again, the data isn't spectacular. It's not clearly better than just ipi-nivo. It's not clearly better than just pembro for PD-L1 high. So what you're left with is a bunch of drugs that are better than chemo. The big thing about the 9LA study was the benefit of ipi-nivo added to chemo was regardless of PD-L1 score, okay? So now you have a true PD-L1 naive immunotherapy regimen, but it's still adding chemo to immunotherapy. So the issue then is mixing together these drugs into cocktails. You get sort of good efficacy with chemo plus IO, good efficacy with IO alone. What about the side effects? So chemo ipi-nivo has about twice as many treatment-related adverse events leading to discontinuation of either the chemo, the ipi, or the nivo. So there is twice as much dose-limiting toxicity, including about a 1 in 3 serious treatment-related adverse events with this combination. And this slide here shows the toxicity of chemo ipi-nivo versus the toxicity of just ipi-nivo, and there is a little bit more dermatitis. There is a little bit more pneumonitis, hepatitis, nephritis with chemo ipi-nivo than with just ipi-nivo alone. So mixing drugs does add toxic side effects. And I actually don't like a regimen with a 40% rash and a 25% thyroiditis. That's pretty toxic. And so you have to be sure that the efficacy is worth it. So here's the algorithm we have in the clinic. We take the PD-L1 score is the answer. So that is a great question, Howard, and that's the problem, is I can't tell my patients what ipilimumab is buying them. But what do I think? In my heart of hearts, I think that we want T-cell mediated efficacy, and we want to do everything in our power to prime a T-cell response. So in my heart, I think dual checkpoint blockade is good, but I don't have the data to give it to everybody yet. And it is more toxic. So this is a segue to the research. Let me just check the time. Yeah, so this is perfect. I'm about halfway through my time, and I'm going into the research portion. So again, lots of new drugs, lots of research. Only one biomarker right now is the PD-L1 immunohistochemistry. Despite this incredibly complex biology, we're really only measuring one thing, and it's a pretty poor biomarker at that. So what's going on in research? I think that there's a huge interest in better biomarkers for predicting which drugs to give to which patient, and there are, rather than just measuring one protein in IHC, there are clinical transcriptomic type gene expression signature tests that are being developed in conjunction with new drugs that measure a variety of genes in the tumor and that take into account all aspects of the tumor microenvironment, including not just the PD-1 protein on tumor cells and macrophages, but also what other cells are mixed in there. How many T cells, how many macrophages, how many fibroblasts are mixed in, what type of T cells are in there. And also, I think, what's going on with the innate immune system within a tumor. And so that a multi-gene signature has an appeal that it will be better than PD-L1 IHC in finding the patients who, say, need CTLA-4 blockade or don't. These are tissue tests. The immune system, they can be, in and of themselves, poorly immunogenic. They can, through their interactions with the immune system, actually turn off the immune system. And I think there's a huge component of, exhaustion, T-cell exhaustion and regulatory T-cells that are turning off the immune response in our patients. This is where I think dual checkpoint blockade would have merit. Having an immune response to cancers makes them evolve and express less of the antigen. And so that's the problem, is we will have moving targets as cancers evolve based on immune response. The clones that survive will tend to be less immunogenic. The tissue microenvironment is full of cytokines and chemokines that turn off the immune system, and there are fibrotic changes and stromal changes that prevent the T cells from penetrating. So this is complex biology, and so in a survey lecture, I certainly won't be able to touch on every one of these potential mechanisms of immune escape. But I will touch upon the stuff that we have in Providence. So what are we doing in Providence? So we have a phase 2 study of an ICOS agonist. ICOS is a co-stimulatory molecule on T cells that functions in the periphery, that a T cell that is primed by CTLA-4 will then be accelerated by ICOS stimulation. That's the biology in vitro, and so the company who makes this antibody, Jounce, has launched a protocol where we are giving ipilimumab to patients who have become resistant to Keytruda. And then after they are primed with IPI, we're giving them an ICOS agonist. And it's a nice straight phase 2 study. And, you know, we love anecdotes. I've got a patient with KRAS G12C, progressed on chemo plus pembro. She's got a KRAS and an STK11 mutation, which I'm not going to talk about, but that would suggest she's not going to respond to immunotherapy, and she's having a nice response to IPI-ICOS. So this is a straight phase 2 with, I think, 90 patients. And then this study is associated with pretreatment biopsy and an RNA signature that they think will predict the patients who will benefit the most from the ICOS agonist, vopratelimab. And this is retrospective data suggesting they might have a way to select patients for ICOS stimulation after IPI. So that study is open at Lifespan. Next, I'll talk about TIGIT. TIGIT is a co-inhibitory immune checkpoint. You could think of it just like PD-1, PD-L1. It binds to the poliovirus receptor on tumors. And there is a drug that blocks this interaction, and so dual blockade of these inhibitory checkpoints might release a greater T-cell efficacy. And in fact, at ASCO this year, a randomized study of first-line combination PD-1 and TIGIT blockade was presented. This study enrolled patients who were EGFR wild type, had some amount of PD-L1, and then were randomized to TIGIT plus PD-1 versus placebo. And again, just in the interest of time, I'll show you that in the PD-L1 high subgroup, there was an efficacy signal that adding TIGIT blockade improved progression-free survival. A nice. And then what about PD-L1 low? No benefit. And so, of course, the makers of TIGIT or the TIGIT antibody are going to develop the combination in PD-L1 high patients for phase 3. They're also interested in combinations with chemotherapy, and so we're going to have cohorts on the phase 1b study adding a TIGIT antibody to standard chemo plus atezo, which is just like pembrolizumab. It's the PD-1 inhibitor. So this study will be open here in Providence. It got through the IRB 2 weeks ago. Another place where immune checkpoint inhibitors is important is with stage 3. And in stage 3 lung cancer, where you're treating with high doses of radiation and chemotherapy, there's a study that gave 1 year of the anti-PD-L1 drug Durvalumab after chemoradiation and decreased the risk of death substantially. So a 30% reduction in the risk of death by giving Durvalumab after chemoradiation for stage 3. So Tom DiPetrillo here and Yarek Heppel and Hina Khan saw an opportunity if we're giving Durvalumab after chemoradiation. Well, gee, why don't we give concurrent therapy? Because we do know that radiation induces double-strand DNA changes. And so you get a synergy between immune checkpoint blockade and low doses of radiation. And so we opened a study giving some additional radiation during the consolidation Durvalumab. This is just a small safety study, 25 patients accrued to see if this is a safe tactic, but also with the hope that we'll have greater efficacy by giving some radiation during immune checkpoint blockade. And along those lines, what about resectable or operable lung cancer? So most of this talk has been stage 4, but for stage 1B to 3A, you may have your tumor resected, and then you may need to take postoperative chemotherapy or adjuvant therapy. And since immunotherapy is better than chemotherapy, there is great hope that we'll be able to give adjuvant or perioperative immunotherapy and then resect. And resection does give you a surrogate efficacy endpoint. You don't have to follow the patient until they recur or die. You can just look at the major pathologic response in the resected tumor specimen, and you wouldn't expect to see much unless you've got them on the right therapy. And so what will that therapy be? It's going to be low-dose Ipi/Nivo and low-dose RT to gross disease pre-op. And it's a chemotherapy-sparing preoperative therapy where we'll resect the patient about 4 to 6 weeks after immune therapy and SBRT. And then we'll be able to study their blood and tissue before and after the immunotherapy. And because this is a talk to try and get Brown investigators interested, I will mention the exploratory biomarkers that will be done on this study. One of the ones that I find very interesting is a genomic test, basically sequencing the variable region of the T-cell receptor. And you can find specific clones of T-cells and then barcode them, and then you can assess blood and tissue for T-cell clonality and density and diversity. And then you can give immune therapy, and you can track the change that you create in the blood and in the tissue just by looking at a genomic test. It's very satisfying to me because if you're trying to find signal and noise, looking at DNA is a very satisfying way to do that. You'll also, of course, look at the resected tumor and look at the tumor-infiltrating lymphocytes and categorize them as well. So this will be an interesting study on the front lines of biomarker research in immune checkpoint inhibition in lung cancer, and it is novel. As far as we know, it's the only study like this in the country doing this. So how might you detect T-cell response in routine care? Patients can have very dramatic changes in disease burden, and they may or may not have, that may or may not be from the immunotherapy, it might be from the chemotherapy. So if you can detect a surge in T-cell activity during therapy, I think that would have diagnostic and therapeutic impact because it would allow you to change therapy or offer some alternative immunotherapy sooner. And that's especially true in consolidation therapy where you're giving like a year of Durvalumab and you're not really sure if you're helping patients. So we want to figure out how to detect T-cell mediated efficacy in treated patients. And my colleagues, Dr. Quesenberry and his colleagues, Dr. Wen, and some HemOnc fellows, Crystal Preddy and Theo Borgovan, are going to be looking at extracellular vesicles in to see if there is a change in the cargo of exosomes, and if they tell you something about the tissue microenvironment or even the host immune environment, to correlate durable responses to immune checkpoint inhibitor with changes in these exosome cargo. And I think we'd be really interested in that day 8. All we're doing is collecting some blood and spit from patients. And so we got a biomarker protocol through that will allow this research as well as any other research where you are only taking disposable or replaceable biospecimens from the patient, where the patient's only risk really is that you're going to go through their chart and you might reveal their health information. So this is going to be an institution-wide patient registry and specimen labeling protocol that will allow you to take biospecimens from the clinic and into the laboratory at Brown and do research on it. And what we've got permission for is anything that you would throw away is low risk, you can send to the lab. So we really don't have permission yet to send accessionable tissue on this protocol over to the lab, but that's a concept in the making. So we're very excited about this protocol, not just only to conduct Dr. Quesenberry's experiment, but to help all of our colleagues at Brown Lifespan do prospective biomarker research. And this is a bird's eye view of all of the clinical trials in thoracic oncology, active and pending. We try to have a clinical trial open in every disease state. We're studying screening, resectable disease, with the immunotherapy protocol on the horizon, unresectable disease with chemorads. We have biomarker research, novel drugs. I didn't talk about small cell at all for lack of time. And then, of course, we work with Howard and Benny Carnero, making referrals to the phase 1 program, because any patient with lung cancer progressing on chemo plus Keytruda really is a candidate for a phase 1 protocol. And all of those immune checkpoint targets, it's really amazing what Howard and Benny have done, have been offered to patients here at Lifespan in various phase 1 and phase 1B studies. We also, and this is, I'll finish with this, we need to take advantage of the fact that we're right down the street from Boston. And I mean, as I divide non-small cell lung cancer up into small little pieces of pie, I'm not going to be able to have a research protocol for ALK or ROS1 or BRAF here, but I keep in touch with, you know, the 50 thoracic oncologists up in Boston, right? There's 5 here in Rhode Island, there's 50 of them up in Boston, and they do have clinical trials for almost every disease state, and I am regularly referring these rare oncogene-driven cancer patients up to Boston for unique clinical trial opportunities. I think that the measure of our success will be when Boston starts referring patients down to us. In order to accomplish this, we need a big team. This is just a snapshot of the folks in our tumor board. And then it takes a village and a huge army in the clinical trials office, and nursing and infusion and across the hospital navigation to manage patients and get them onto clinical trials. So none of this is possible without a big team effort. And you can really contact any of our wonderful clinicians and they'll really know what's going on, because we have a very close communication with the team. So that's the last slide. So I hope you got an appreciation for the state of the art, what ipilimumab means, the issue of gene-targeted therapies and subdividing the disease, and then some research protocols up and running in Providence. And I'm happy to take any questions you may have.
Thank you, Jerry. Maybe I'll get the questions started. Can you comment on potential opportunities with existing lung cancer tissues within our hospitals?
Could you repeat the question, Wafik?
Opportunities with existing tissues, lung cancer tissues, and some of the future directions, maybe with organoids that may come from new tissues.
Yes, historically, we have not banked lung cancers. So we don't have a big biobank here of early stage or even metastatic lung cancer. We do have, 20 years of formalin fixed paraffin embedded specimens, and we do retrospective research. If you have a biomarker of interest, we can interrogate our what we have informed. We get an IRB approval to get archival tissue from patients who have died and study that. But we don't have a biobank. I think that moving forward, almost all of our clinical trials have tissue correlates, and if there are investigators interested in lung cancer tissue, we can figure out how to start sharing tissues prospectively. So, for example, organoids, I think you'll be able to use the disposable biospecimen protocol to bring malignant fluid, pleural pericardial ascites, over to the lab and get cancer out of it, and then grow it in the lab and establish organoids for translational laboratory projects. So that's up and running now.
All right, other questions?
And I'm sorry, did you get that answer? I might have been talking.
Yeah, great answer, Jerry. If anyone has questions, please unmute yourself and ask the question. All right, well, I'm not seeing other questions. I'm not sure if you all heard what I was saying because it's raining really hard right now. Thank you very much, Jerry. It was a great presentation this afternoon. Thanks for everyone's participation as well. Have a good afternoon.
Thanks, Jerry. It was great.
Thank you very much.